Welcome to the next installment of the Many Minds podcast, where we encourage collaborative community care using many minds for better outcomes. I'm Alex Davis, physician assistant, along with Tyler Murray, nurse practitioner, and the two of us work together at Summit Brain, Spine, and Orthopedics in Lehi, Utah. The purpose of this podcast is to promote interaction between specialists, dig into what makes your specialty special. I want to talk about the stuff we don't always get to talk about as healthcare providers. What's life like in your shoes? How can we support what you do to provide better patient care?
And with that general disclaimer, this podcast represents the opinions of myself, Alex, and any guests that we have on the show. The content from this podcast is not intended to be a substitute for medical professional advice, diagnosis, or treatment. We're just here to talk and have a good time. And with that, we'll jump into the episode. Today, we have Mark on the show with us. And Mark, you are a certified registered nurse anesthetist. Did I get it right?
Yes, sir.
Oh, my gosh. Yeah. AKA CRNA, as people might hear out in the medical world. So we just kind of want to talk to you and get to know you in your space and maybe let you introduce yourself and kind of what you do on a day-to-day basis. So I'm going to give the mic to you.
Awesome. Well, happy to be here with you guys. So I'm a CRNA. I've been one since I graduated 2018. So I've been practicing since 2019. It's been an awesome profession. I grew up, I wanted to be a CRNA because I grew up in Manti. My dad was an accountant, and so he does taxes for other people. And some of the people he did taxes for were anesthesiologists. And he's like, you know what? Those guys always seem super happy. And yes, they make good money. And I was like, man, well, what would it take to be, super happy, doing well, and then living in Manti? So then I started looking around, and in those rural hospitals, they only have CRNAs. And that's why I was like, dude, I want to do the CRNA route and hopefully end up back in Manti. Obviously, that was 6 years ago. I'm practicing in Utah County. So the dream is one day to end up back there. But that's kind of where I'm at now.
Yeah, to supplement that, I have not yet met a CRNA that is not happy with their role and what they do and their lifestyle. So we're going to dive into that, I think, a little bit later. But so kind of tell me about your journey to become a CRNA. I think most of us know that are in the medical space, but maybe some people that are interested in becoming a nurse anesthetist, kind of what did that process look like schooling-wise, required time, in the medical setting? Kind of walk us through that a little bit.
Okay, for sure. So for me, I think it's a little different now. So I graduated again in 2018, and now I think a lot of schools have moved to their doctorate, DNP. So I'll walk through. I'm an MSNA, Master of Science of Nurse Anesthesia. But my process was I started at Snow College. I got all my prerequisites for nursing school. And then I did nursing school up at Weber State University, which I had phenomenal time. Yeah, let's go. I think both of you guys went there. So Wildcat Pride.
Yes, sir.
So I went to Weber State. I graduated with my bachelor's of nursing, so BSN. And then from there, there's a certain amount of time you have to work in a critical care unit. So my time was at McCady Hospital, which again, phenomenal nurses. I learned so much working in that ICU. I was there for, I might say the wrong time. I'm going to guess I was there for 3 years, just kind of guessing, maybe 2 to 3 years. And then from there, I applied to a few schools and I got accepted to Westminster College in Salt Lake. Again, super awesome. I had a great experience there. At the time, there's a few other schools I wanted to go to. And I was fortunate enough to get accepted across the table. And I told my wife, well, do I keep looking? She said, no, we're staying. So I ended up sticking around. Went to Westminster. And
that's impressive.
After that, I've just been around Utah County ever since, just helping people, just different groups here.
Now, when you were, sorry to interrupt, when you were nursing, did you have to sign a contract like that you would commit so much time? My experience was when I applied for the intensive care unit, they were very leery of a male registered nurse coming into the unit. Like, what are you trying to do? Are you trying to just move on? Because we don't want to invest all that time and energy if you're just planning on packing up and leaving in a year or two. So was that a thing when you were in that setting?
It kind of was. I didn't sign any contracts, but it was definitely, here's a young, 20-year-old guy, and he's using this ICU as a stepping stone to get into CRNA school. So I remember I fabricated a lot of stuff like, no, I want advanced, which was, a lot of it was true. I was working the step-down unit at McCady Hospital at the time, which we took care of some pretty sick patients. And then to move up to the ICU, I said, I'm kind of the point where I'm getting bored of IMC, was what the unit name was, and I'm just ready to start doing, more critical patients. Yeah. So when I was there, I just remember I was sitting down with the nurse educator, and she's like, look, do you want to be a CRNA? And I was like, yeah, I do. So then she's like, it's totally cool. Like, we'll train you up. We'll get you as ready to go. And then it's kind of funny. I don't know if it's still there, but they started making these books they called all of us guys that went on to CRNA, like the Lost Boys. So we were like all the boys that just came and left.
That's
and
cool.
I mean, I don't know how many people are still in that unit, but I know a lot of us have gone on to be CRNAs from working that unit, which is kind of cool. So
you can definitely see that from the employer standpoint of having not a lot of retention of their good employees, because I imagine it's probably the better employees that do end up going on and furthering their education and careers and things. But at the same time, that's different coming from the PA background, because we don't have that kind of clinical training to get into schooling. So I can imagine that's got to be an excellent background and training and experience as you're getting into further your career.
I mean, I remember like sitting down with some of the guys, like, for whatever reason, there'd be night shifts when it was just like a bunch of people that are like, going to CRNA school. And I just remember like sitting down talking about it, like, oh, I can't wait till I'm all done. Like, I don't have to do this grind anymore. And I mean, ICU was heavy, but I remember leaving the ICU and being terrified to become a CRNA. Like, it was so eye-opening, like the transition from working as an ICU nurse and then being a provider. Yeah. So it was a pretty, I mean, terrifying gap at the time. Anymore, like, it's like, I don't know what I was scared of. I mean, if I could tell Mark back then, like, it's actually like an awesome job. I'm super glad I did it. But leaving the ICU, I was like, dude, this is next level. I don't know. So
tell me a little bit about the experience, because again, being unfamiliar with the nursing background, you've got to choose. Once you're an established RN and you've got good experience, some of them go to become nurse practitioner. And then you chose similarly to further your education in nursing, but as CRNA. How and why, or who would choose to do one or the other? Or what does that scenario look like if you're a nurse?
So for me, the most beneficial thing I did was I shadowed anesthesiologists. I shadowed a lot of CRNAs. I went down to rural Utah and shadowed one of the CRNAs down there. Awesome guy. And that was really beneficial to see, okay, this is what they do. This is what they're doing. And then, I mean, my cousin's a nurse practitioner. She's awesome. I shadowed her and I was like, I don't know that I want to do clinic. I mean, it would be a fun part, but for me, I really like the critical care, the pathology, the physiology. I like that area.
You like the comatose patients.
I do, yeah. No, I mean, someone told me yesterday, they're like, man, you really do a good job talking with patients. I'm like, yeah, I do good for about 3 minutes, and it's like, all right, lights out. Like,
now I'm going to put you to sleep.
Now we're done.
Cue the music. Let's go.
So...
Yeah, that's cool.
That's awesome. And it's such a cool environment. We love being in the OR with you guys, because you help create such a good environment now. You guys are a crucial role for the surgical team and in the surgical environment to keep everything going. Tell us a little bit about kind of what you do then day to day. What's life like a day in your shoes?
So I wake up about 6. No, just kidding. No, I mean, for the most part, my day is I try to see the patients pre-op, get a quick rundown of like any past medical history, see what's kind of going on with obviously what they're having surgery for, and then I'll talk to the patient, and then I try to tailor the anesthetic to them. If they said, hey, last time I had surgery I had super bad post-op nausea, I might try to not give them anesthetic gases or stuff that could cause post-op nausea. So I try to talk to them, tailor a plan to them, decide like, are we going to go general, MAC, whatever it is that we're going to do, and then from there I go set up the room, get everything ready on my end, and then bring them back. When they're in the OR, obviously we get them to sleep, sometimes like pop in a breathing tube, get them positioned. And then from there, it's like, cruise control. Honestly, as soon as they're asleep, everything looks stable. It's cruise control. It's fun to like, talk with people, watch the surgery, see kind of what's happening. And then at the end of the procedure, as things are wrapping up, cut off the medications, reverse whatever medications we need to if they're, under, the heavy muscle relaxants that we use or whatever, reverse them, and then get them moved over to the PACU and wash and repeat,
Yeah. And I guess I'm still learning about this as well, and I'm sure there's a lot to learn. But from the other side of that, watching this happen from the surgical team, to me, I just assume anesthesia is just anesthesia. Somebody needs to be asleep for surgery, they're just going to take care of it. But it sounds like it can be quite a bit more unique and tailored. What are the kinds of things, or how is that unique and different for each patient? Tell me a little bit more about that.
So, I mean, yeah, again, like looking if they have, for example, everyone's heard, I mean, maybe not everyone, but like malignant hyperthermia, if they have that, I try to go prepare a machine that has no anesthetic gases. I don't use, succinylcholine, different medications like that could trigger malignant hyperthermia. So I do that, or, hey, I was super nauseated last time, we'll give them, a sticker scopolamine patch and try again not to use gases, or, maybe if we could use a spinal, use a regional technique or whatever form of anesthetic we can do so that they're asleep, comfortable, and able to tolerate whatever surgical procedure they're having. So it looks different for every patient. So
yeah, that's interesting. I guess I didn't pay much attention that you guys are so tailored and unique to each patient.
Yeah, try to be.
It's not just you go to sleep and then wake up when you need
on
to.
and off switch.
Yeah, it's not an on and off switch. Exactly.
I've been impressed with how much happens under the scene. I mean, you're managing their heart rate, their blood pressure. There's a lot of things going on that you have to be responsive to. Sometimes you guys get the crack of like, oh, you guys are just sitting in the corner, but you're actually, I mean, you're responsible for that person's breathing, cardiovascular status. I mean, it's a big role. I think a lot more than what people might initially think when it comes to anesthesia, if you will. So that's really cool. And then the autonomy of it, I think, is really what captures me. Like for me, I became a nurse practitioner because I wanted more autonomy. As a nurse, I would take care of patients and I would almost be able to tell what their needs were, but I couldn't do it because I couldn't order things by myself. So talk to us a little bit about that relationship with the anesthesiologist. You guys have a lot of autonomy in your setting. And what's been the buy-in from the anesthesiologist group in your area? I know it looks different everywhere and different kind of thoughts and theories about how to utilize a nurse anesthetist, but kind of tell us what you've experienced in that setting.
Yeah, so I work with some great physician anesthesiologists. I have tons and tons of autonomy. I was just telling you guys earlier, I go to dental offices where I have no anesthesiologist. I go to rural Utah occasionally where there is no anesthesiologist. So in those aspects,
you're the guy.
It's it. So it's like, not turning around like, oh, hey, I need help. It's I am it. And man, I tell you what, I've been in some situations that are like, shoot, like I'm glad I've got the experience I have because this could go really bad if not. But then other places I've worked, it's, really a lot of physician anesthesiologists are pretty hands-off, and there's different kinds. I've noticed there's some that run their anesthesia groups as a business, so for them they don't care about who's pushing induction drugs, who's doing the nerve blocks, who's doing what. It's just it's a business. It's my 9 to 5. I just come, do it, expect the CRNAs to do it all and step out. There's other groups where the anesthesiologists are more, and I haven't worked for these kind of groups, but I know that there's anesthesiologists that are more like hands-on, like they want to be there for every induction and emergence. But yeah, the groups I work with right now are so awesome that, they let us have autonomy. And if I do like, hey, I need to bounce this off you, like this patient has, yesterday I had a patient that had a gene mutation I hadn't seen since school. So I hurried and looked it up, and I was able to bounce it off the physician anesthesiologist, and say, hey, what else would you do? What am I missing anything? Because, fortunately I still have red flags that go off. They're like, hey, this is something that could go bad. Like I can't remember it. So it is nice in those situations to have someone else.
Some colleagues and some backup. And
100%.
So
yeah, 100%. And the other thing is just your balance through the day as well, because we get a little bit jealous during long cases. And I get to see Mark get tapped out and goes on a bathroom break or takes a lunch break or something. Yeah, because you guys got a whole team supporting each other, which is awesome. And then I get to ask our surgeon, did anybody tap you out for lunch yet? And it just doesn't happen that way. So the environment at work seems to be excellent as well, with just your team and who you work with.
Yeah, and I feel like that's the way it is with all the anesthesia. I can't speak for all the groups, but for the ones I've worked with, it's like, they're like, hey, do you want a break? And I'm like, okay, look, I'm good. Like, seriously, I'm good,
Yeah.
I think my favorite saying in anesthesia is it's 1% sheer terror and 99% like easy. Like for, and for like the short amount of time I've been a CRNA, I feel like that's so true. It's like, for the most time, we're just, having a good time talking with you guys. And I know sometimes surgeons can get a little frustrated, and so I'm like, all right, I better not, no talking right now.
But we as Advanced, we embrace it. We embrace it. We want that conversation to happen.
Yeah,
for sure.
So it's great.
Yeah, have you found any kind of tips and tricks, or what is that like? What experiences have you had in the different settings? Because it's a completely different room based on the surgeon who's working in there and what kind of atmosphere and culture they foster. What's your experience been in that way?
Oh, to help a upset surgeon?
Yeah. And how do you deal with that, and what's different and unique? And
so, okay, first off, you guys know I love music in the OR. I love it so much. But one of the first things I do is like cut the music. All right, like whoever the surgeon is, they are having a hard time. Like read the room, cut the music, and then just say, okay, what's going on? Like, and I like to tell the surgeon like, hey, they're doing good up top. Everything looks good up here. Vital signs are stable, just so that they're assured like, okay, they're good on that end. I can focus on my side of the drapes and just kind of see, what's going on. And then hey, do we need to get someone else in here? Do we need a second set of hands? Just so they know, like, people are paying attention to what is happening, because I'd be pretty mad if I was trying to do something and, no one's paying attention. So just let them know like, hey, we're all here together. What can we do for you? I think is one of the best things to do to help an upset surgeon in that situation. Yeah.
How about having to give feedback on your end to the surgeon if you needed some help or you needed something or something was alarming on your end?
Yeah, if something were to happen, knock on wood, I haven't had any crazy experience.
Right.
But
sometimes you see like elevated blood pressure, heart rate, or oxygen
like, hey,
dips or
are you guys
like
losing blood? Yeah, like, hey, we're losing a ton of blood, or hey, something's gonna happen, like monitor this, or I've had that feedback too from surgeons. So, I'll watch the monitors a little bit more close to what they're, what they're saying. So it's great to have that like open communication in the OR, so that if anything happened on one side or the other, we know kind of what's going on.
Yeah, and it's great that you've got a relationship with the surgeons, which I know you're great at as well, getting to know everybody that's going to be in the room.
Yeah.
We had one just the other day. We were doing a case on the cervical spine, and the access point, part of that is moving the carotid artery out of the way. And anesthesia gave some feedback saying, hey, just so you know, looks like the blood pressure is spiking pretty high right now.
Yeah.
And so it was helpful, because then we can reposition the retractors, just verify again, carotid artery is doing okay in that scenario. So it's a good team environment to have you guys involved in. And giving some feedback.
Let's switch gears a little bit. Let's talk about the work-life balance a little bit. Let's talk about how many hours you think you put in a week, what your schedule looks like, and then, how much off time you have. Because I think people will be interested to know from a nurse anesthetist perspective what that looks like.
Okay. I don't think I've struck like a perfect balance myself. I think I work too much, to be honest. Like I love hustling right now. My dad's saying growing up was make hay while the sun's shining. And like, it feels like in healthcare, the sun's always shining. Like there's a lot of days.
That's what they do in Manti.
That's right. Yeah. So, I haven't hit like a good work-life balance, but I know like a lot of groups, the average time off, our group's at 7 weeks. I know there's groups at 8 weeks time off, paid vacation through the year. And then really you can play with like, for places that you do call, you can get a post-call day. So if you work one call day a week, you have, one post-call day. So you might work, 4 days a week is all. A typical week, I don't know how many hours I'm at it this week. I'd probably say 60 hours average with, and that's including, call shift, which could be super easy home at night, or, I might be stuck all night, like managing epidurals or doing late cases. So that'd probably be like my average. So
how much call do you take typically?
I do.
What's common, I guess?
Yeah, for everyone it's different. So for me, I do 1 call day a week, 1 weekend a month up here. I know other facilities, there's guys that do call like, I think it's starting like Sunday night, and then they're on all week until Saturday night. So they switch off. So they're like 1 week on, 1 week off. They only work 26 weeks a year. So that's why like the rural sounds so appealing to me, because working half the year sounds incredible. So anyway.
And then you're involved, you kind of alluded to that earlier, of not just your day job, but you've got the opportunity to PRN and moonlight and do some other things and get involved in other areas. What are some of the areas that, you're involved in, or what are some common areas that CRNAs are? Yeah,
I think so. Utah right now, it's huge. Dental anesthesia is just hitting the market hot right now. And maybe it's been here longer, but it just seems like to me it's the next big thing. Like, so people are going into dental offices doing full-blown dental anesthesia, like, a tiny room. They're putting patients under general anesthesia so they can have, full mouth extraction with implants. That's huge. I've seen on social media, some people are doing anesthesia for like tattooing. Personally, I don't think that's something I'd ever get into, but I know some people are doing that. I think I do like the typical moonlighting, though. I go to some plastics offices. There are people doing ketamine clinics as well.
Oh, yeah.
So I haven't got into that. I might jump into some ketamine clinics. So, but yeah, there's so much. I know for myself, I do a little bit, but there's other people that do a lot more than what I do.
And traveling, I don't know if that's newer, but I know since the COVID times, the traveling gigs have been prevalent. What's life like for somebody that's traveling?
So for the few that I know that travel, they go out, I think like 1 week period, 2 week period. They're out traveling, making, I'm going to say it, like insane amount of money. And then they can come back here to Utah and be home for a couple weeks. I love Utah. And I'm just saying this because I know a lot of CRNA Facebook groups probably would blast me. But
yeah.
I mean, Utah's CRNA wages aren't, what they are outside of Utah.
Yeah.
But I mean, I'm sure that's how
I think it's pretty comparative in medicine. I think Utah's on the lower end. Yeah.
But I mean, if someone's entrepreneurial enough, I feel like you can do pretty well, like moonlighting, giving up sleep, maybe burning a few vacation days to run around. So I mean, maybe I'd travel. My wife and I always were like, hey, if we move, here, we could travel. You could be away for 2 weeks, but I don't know. My kids are so small that I don't want to travel, but it's definitely like, I got to put the blinders on and not see how much money these guys are pulling in, because it seems pretty appealing.
But I mean, also lends to just options in the future. It seems like maybe that's not right now for you, but
yeah, for sure.
Something to keep an eye on, it sounds like.
Yeah.
Very cool.
What would you say the realistic expectation for a nurse anesthetist in this area to expect to make? Let's talk about just general work hours, maybe not all the moonlighting and on-call stuff, just kind of a general salary.
So, I mean, obviously people can work more, work less. And again, this is one of those things like, I don't know. I know, like, someone probably could start out and make, work some really good hours and not make as much. I know. And then again, like the pay for CRNA is probably similar to like what you guys are, but it's like you can either be 1099, W-2. There's a model that it's called Eat What You Kill. So every case you do, you bill it, you get a collect. There's hourly. So there's a lot of different like factors. Yeah. So I think like for a 1099 job, I recently saw was starting at about $240 for the year. And that was before call, before everything. So, 1099. So you got to factor in all the extra you got to pay off. Yep. I know of people. So I don't know like what the ceiling would be for a CRNA in Utah. I mean, I would guess. I know of guys making roughly $400, and beyond that, I really don't know. But I know there's people that probably make maybe upwards of $5. Again, if you are willing to be, work all the time, I'm assuming more. But that would probably be my range.
Man, that is intriguing I think to me, but probably to more people. Just options, potential. You can kind of get out of it what you want to, it seems like.
Yeah, for sure.
And maybe even for some that want a part-time gig, or maybe it's a mom that's working, part-time stuff. You can still do decent and can control what you want to get out of it.
Yeah, 100%.
Yeah. Same for you, right? That's how your job works.
Well, yeah. Yeah, we didn't want to tell you that, but no. I think that's interesting. I think a lot of people probably want to understand a little bit more about what's new in medicine as far as anesthesia goes. So is there anything new in your world, in your space, that you're seeing utilized in medicine?
Yeah, so like for me, the interesting things to anesthesia aren't what's happening in the OR per se. It's stuff that's happening outside of the OR. When I first got into CRNA, one of the big things was like ERAS, which is enhanced recovery after surgery, was huge. And then trying to use opioid, like sparing to opioid free anesthesia. So that was a huge one. Along with that, and I don't know how recent this is, but I know some people are doing what's called so this is to go along with ERAS, but it's called EBU, which is extracorporeal blood oxygenation and ozone. So essentially what they're doing is it's kind of like a hyperbaric chamber, but what they're doing is they put in 2 IVs, they take blood out of one side of your body, they oxygenate it, and then put it back into your other side of your body. Right. So it's just like through a hemodialysis catheter that essentially is able to oxygenate your blood, get rid of a lot of stuff in your blood, and it helps recovery afterwards, kind of like a hyperbaric chamber would. So instead of doing it hyperbarically, there's CRNAs I know of that are doing that.
That's its own treatment, just to stand when somebody goes in to have that done, kind of like what would be dialysis, I guess.
Yeah. So I mean, there probably are like nurse practitioners doing it, but I know of CRNAs doing that. That's one. Another one that was really fascinating is the stellate ganglion plexus block, which I don't know if you guys have heard about that one, but they're like injecting. I've watched it. I know CRNAs that do it. Never will I. No, it's one of those procedures. I'm like, I'm good. But they're injecting like the nerves into the neck, which is able to help with like long-term COVID, PTSD. Like people are saying instant like depression gone, like anxiety gone. And again, this is all what I'm reading on Google, so we know how accurate that is. But it's been pretty fascinating what it's treating. So people have been using ketamine and like there's all those things, but this is kind of like the new like, hey, maybe this could treat,
what kind of clinic, what kind of setting is that being done in?
just like an outpatient, like a pain type clinic.
Sure.
So
okay.
people are just able to go into, these offices and get the procedure done. So
That reminds me of a question. So if you were wanting to venture into that space, could you do an independent clinic in that setting, or would you have to have an anesthesiologist overseeing?
CRNAs do it independently. Yeah.
Wow.
Yeah. So they can do that. There's a pain management fellowship for CRNAs. They can get that and then do like pain type procedures.
You could have your own business, your own.
Yeah. Do like RFAs, all that. Yeah.
Really?
So it's really cool. Yeah.
Did you know that?
I did not know that. I'm learning things today.
Absolutely. That's why we do this.
One of the CRNAs I know that's from Central Utah, he went and got his pain fellowship, and he's doing all the pain management stuff at one of those hospitals.
Who's teaching and training in that setting?
I don't know. I haven't looked into it enough to know. I know TCU is the one school that offers
through a nursing background, or is this the actual PM&R docs that then are turning around and training the CRNAs? You think?
I don't know that. I don't know on that. But I just know the CRNAs are doing it. Yeah.
They have the autonomy to do that. That is fascinating.
Yeah. Interesting. Cool. What's your favorite procedure to do? What kind of stuff do you actually like the most?
Oh man, I love it all. Like, I don't know. I love doing just the procedures. I love intubating. I love doing like lines. I love doing epidurals. I love doing nerve blocks. It's just, I don't know. I just love doing all of that, and just, I don't know, seeing patients like have a great outcome is probably, I know it's stupid, but like, honestly, like when people are like, hey, you know what? That was the best epidural I ever had. I'm like, yes, like awesome. Good. Or like when people, when patients wake up, they're like, oh, we're done. Like, that's also great. So I can't tell you like a specific thing I do, but I don't know, seeing
just like the hands-on aspect of it. It sounds like,
and then good results. Yeah.
Well, that's awesome.
And happy PACU nurses, right?
Exactly.
Like if they're happy with you,
exactly.
you're doing something right. Yep.
You know too well.
Yep. 100%. Yeah.
That's awesome. How about another fun thing we like to talk about? I'm sure you've got plenty. Is give us a good, fun patient story.
Oh man, I got a few. One that happened recently, dude, this was funny. So we're in Utah, I'll just say that. We were it was at a plastics clinic, and we had the patient prone, face down. And at the end of the procedure, I wake my patients up pretty quick, so they'll be like face down. And as we woke her up, I hurried and extubated her, pulled out, and she started crying. I'm like, oh no, like she's hurting. No, she was mad because she thought she was at SWIG, and all of us in the room were her friends, and she was super mad. She was totally fine, but she's like, I was ready to get my SWIG drink, my SWIG order, and I woke up to you guys. Like,
no, you ruined her dream.
Yeah, so that was pretty funny. So that was a good one.
Awesome.
Another one was, it was this kid that was a lifty from Brighton, and he broke, I don't remember what it was, but it was an ortho case. And as I put him on the table, gave him some Versed, some ketamine, and he's laying there and he's like, man, I just feel like a brain right now. And I was like, all right, we'll get you sleep. He's like, no, can you wait a little bit to put me out? And I was like, oh, all right, put him out. But that was pretty
this high for a second
too. But
that's funny.
I mean, there's so much from the day to day. Like, I don't know. I don't know if I'm just like over it now, but sometimes it's like, it really has to stand out at this point.
Your new normal is probably a different than the rest of us.
Yeah.
Which is funny. Do you ever hear people, I hear sometimes, and maybe you've heard the same too, Tyler, of patients that have some sort of recollection of their anesthesia. Well, they say, I must be different or unique. You got to take special care with me because I woke up during anesthesia during my last procedure and I remember things. Is there validity to that? Is that real?
Yeah, I mean, it certainly is. So this, again, going back to like how we tailor the anesthesia to different patients, sometimes depending on the type of anesthetic we do, I mean, I'm going to say it, yes, patients could be aware under anesthesia. So like if you're getting a colonoscopy done, it's just a IV medication, sometimes patients might wake up and remember a little bit of the tail end. If you're getting like an eye surgery,
they remember for sure.
For sure, pun intended. And then like eye surgery, we have patients, pretty awake for an eye surgery so that they can focus on like the lenses and what the doctor's doing. Some pain cases, we like to keep our patients pretty light so that they can talk like, oh, do you feel this on the right, left? Is this, so when the pain doc's working, they like the patient to be a little bit more aware so they can communicate. Other instances of like open heart surgery, I mean, I guess it's super stimulating. So patients can remember that part of the surgery as well. And then, if heaven forbid you run out of like your anesthetic gases, a patient could be, completely paralyzed with your paralytic and, your gas runs out, which is
Creepy.
sedating them, and you can be completely awake, which, I mean, terrifying. So it's one of those things I always like double check, triple check that on the monitor you can see what their gas level is. You can make sure that they're like asleep, they're not, and again, going back to like the communication with the surgeon, sometimes the surgeon's like, hey, they're moving a bunch. They're moving a bunch, or like they're getting tight, it's like, oh yeah, let me hurry and, it's been a minute since I've paralyzed, let me hurry and check and get them like more paralyzed and out. So definitely could happen, knock on wood. I haven't had a patient say it, so
good.
Hopefully we'll keep that way.
How about we had one of our episodes, we talked with Morgan Unga with the orthopedics.
Yeah.
Great guy.
Yeah.
But he was telling us that they did a total knee arthroplasty and the patient was awake intentionally.
Yeah.
That they chose that they wanted to do their case conscious.
Awake.
Yeah. How do you feel on your end in that scenario?
Depending on the patient, I could do it because we do C-sections all the time with awake women.
Right.
And sometimes it's great. It's like, oh, hey, here's your new baby. With a knee might be kind of interesting because you guys are down there ripping with saws and all that jazz. That I don't know. Depending on the patient, if someone's cool, I mean, it could be fun, but I don't know. That one's a patient dependent. But yeah, you totally could just pop in the spinal and let them hang out.
That's crazy.
That's still wild.
Yeah.
Put the mirror up. Yeah, you want to watch this? Yeah. Live footage here.
And again, going back to like, I don't know how accurate Google is. I think I saw someone had like a kidney transplant with just a spinal on board.
Oh my goodness.
So again, don't quote me on that one. But I think I saw
that's
that.
I'm
going to pass.
Yeah.
On doing the kidney transplant, even
for
to begin
sure. Yeah, I'm very much. You pay for the anesthesia, you get the anesthesia.
That's right.
Yeah, we're going full send. So
I love it. That's great. All right. Well, we should probably wrap it up. Mark, it's been awesome having you here.
Great being here.
Tyler, my favorite question of the day. What'd you learn?
Dude, this was awesome. I learned so much today.
I love it.
I didn't say this before, but I wanted to be a nurse anesthetist. I went into nursing school to become a nurse anesthetist. And then like you talked about, you find kind of your avenue, and my avenue led me differently in family nurse practitioner, which is great.
Yeah.
But man, just learning about all the uniqueness, like you could be in the dental office, you could have your own practice, you go to pain management. I think learning the diversity within the anesthesia world, like I knew about it from a physician lens, but learning about it from an advanced practitioner lens, like that's amazing. Like that's awesome. So, and then all the unique stuff that's happening. I think we have so many opportunities to grow and learn, and so many treatment modalities that we want to offer patients. It seems like anesthesia is like on board with that and trying to follow that through. So it's so cool to see. So I thought it was great, very eye-opening for me.
Awesome.
Cool.
If somebody wanted to find you, Mark, if somebody had follow-up questions, wanted to chat with you, get to know you, maybe learn more about what we've talked about, how would somebody connect with you?
I mean, I work with you guys enough. They could just hit you guys up and point them in my direction for sure. Yeah.
We'll point them your way. Perfect. Okay. Well, if you want to connect with Summit, you can find us on Instagram at Summit Brain, Spine, and Orthopedics. Our YouTube channel is the Summit Medical Institute. And as always, we like interacting with people in person as well. So come out and see us Tuesday morning, 7 a.m. at the Mountain Point Hospital in Lehigh for our interdisciplinary case discussions. Special shout out to our production team, Dallin and Amelia, all the hard work that they do behind the scenes. And as always, we'd love to hear from those that are listening. Please give us some feedback. Let us know what's working, what's not working, any topics or specialties you want to hear from. And if you know somebody or you yourself want to come chat with us, we'd love to hear from you. So looking forward to what's to come. We got some great ones coming up as always, so please stick with us. And this has been another episode of the Many Minds podcast, where we encourage collaborative community healthcare using many minds for better outcomes. I'm Alex Davis.
I'm Tyler Murray.
And thanks for being with us. We'll see you next time.